Hello and welcome back to CCRN Review. This is the gastrointestinal section. So in the GI section here, there's a number of different disease processes that we need to take a look at that are on the test map. So let's go ahead and get moving right into the first one, which is GI bleed. GI bleeds, about 55% of them occur as a result of peptic ulcer disease. So the patient has whatever risk factors that lead to development of a peptic ulcer and then end up having some GI bleeding. Esophageal varices. Now, wouldn't you think that that number would be much higher than 14%? Because those are the ones we remember, right? That's the patient who's just, vomiting up tons of blood. It's bright red blood. They're in hypovolemic shock and, they're just a train wreck. But esophageal varices are only accounting for about 14% of our GI bleeds. Now, keep in mind, too, that when we're talking about the ICU, lots of patients with peptic ulcer disease and a GI bleed never go to the ICU. They're managed either on the floor or they're managed even in an outpatient setting where they have this peptic ulcer disease and some GI bleeding, but they're not at the point where they're hemodynamically unstable. AV malformations for 6% and Mallory-Weiss tears about 5%. Tumors and erosions 4% each, and then other is the last 12%. So let's take a look at some of these things that can create some irritation to the stomach lining. So caffeine as a stimulant is going to increase acid production. Vasopressors will decrease mucosal blood flow. So vasopressors are causing vasoconstriction, and they cause it not only in the periphery to increase your blood pressure, but also they're going to cause vasoconstriction around the stomach, and that decreases our mucosal blood flow, and then the mucosa can become eroded. Aspirin, alcohol, and steroids all create more hydrogen ion back diffusion, meaning that there's more acid left in the stomach. Corticosteroids decrease our mucus secretion, so we have less mucus lining in the stomach, and that then opens up the stomach wall so that we're more likely to have erosion. Chemotherapy and steroids will decrease our cell renewal. The GI tract will renew the cells very rapidly, in fact, maybe as quickly as every 24 hours. So if we're giving chemotherapy and steroids and we're decreasing that cell renewal, we'll have damage occurring to those cells, or we'll just have them become old and die and have to be replaced. And then we won't be able to replace them as quickly because of the chemotherapy or the corticosteroids. So prevention activities is we can take a look for H. pylori. H. pylori is a bacterium that is found in the GI tract, and in fact very common that we're going to see H. pylori in the GI tract. Interestingly, H. pylori is something that we pick up very young. So, playing in the sandbox with the other kids, and it's transmitted by a fecal-oral route. So someone goes to the bathroom, doesn't wash their hands, and they pass it on to the next person. So we get that transmission of H. pylori. Now, normally you don't notice any problem with H. pylori in the GI tract, but H. pylori can make the stomach lining a little bit more sensitive. And if there are additional risk factors that are involved, or some people are just a little bit more sensitive to H. pylori, then that can eventually lead to erosion and we have a GI bleed. So H. pylori might be one of the things that they'll try to treat. Unfortunately, there is a lot of times, even if we treat it with antibiotics, we'll see the H. pylori come back. About an 80 to 90% eradication rate, but that means that there's a 10 to 20% rate of reoccurrence. NSAIDs and COX-2 inhibitors, these are medications that we give to patients to decrease pain. They're very effective in that they decrease inflammation and at the same time decrease pain. However, they do so by decreasing our prostaglandin secretion. Prostaglandin is helpful or necessary, in fact, to be able to maintain the inside lining of the stomach. Most of these are uncomplicated and asymptomatic. You just stop the NSAID or stop the COX-2 inhibitor, and then the GI distress or the GI bleed resolves. Stress. So we hear of this all the time, stress ulcer. I'm getting a stress ulcer because of my job or whatever. Well, this is a real thing that happens in our patients in the ICU, about 1.5% of all ICU patients. Probably a combination of different things going on here. Medications we're giving to the patient, the lack of food in the stomach. There's probably a lot of different things that are going into this process. In addition, of course, we do have stress, and that's releasing cortisol and epinephrine and all of those kind of things that decrease our mobility of the GI tract and decrease the secretions in the GI tract. So all of those things together kind of open up our patient to developing some erosion of the GI tract and maybe a GI bleed. The problem is, of course, that if our patient develops a stress ulcer, it's only 1.5% of our ICU patients, but the mortality is much higher, especially if the patient is admitted with a primary diagnosis of upper GI bleeding. Some independent risk factors include respiratory failure, that sounds like a lot of our patients, and coagulopathies. Well, here we go with esophageal varices. So you knew that one was coming, right, as one of the different ways that we have GI bleeds occur. Esophageal varices are varicose veins. So just like you see varicose veins in the legs, the same thing happens here. We get these stretched out, pouched type of veins that occur around the esophagus. Now, the problem being that if we have these kind of outpouched veins occurring around the esophagus, that stomach acid can reflux back up into that lower esophagus, and it can start to erode those veins. Now, the other thing that is interesting about esophageal varices is that these veins are under high pressure. So it's a high-pressure venous bleed. Now, normally they wouldn't be. If you're a normal, healthy person and you don't have a liver that's got cirrhosis, you're not going to have high pressure in these veins around the esophagus. But we start to get a backup when the patient has cirrhosis. We'll start to get a backup of blood, and the blood backs up into those veins around the esophagus. That's what causes them to outpouch, in the same way that we get varicose veins in the lower legs. They happen because people are standing on their feet a lot, and so the backflow of blood pushes against those vessel walls, and eventually they outpouch, and we have that varicose vein. Treatment. Well, really the most common treatment we use, and probably the most effective treatment, is blood pressure management. So keep that blood pressure down so that the patient is not having a high pressure in those vessels. And then we may have to use some additional components here, like vasopressin. We may have to use nitroglycerin. So what happens is that combination is that we're trying to improve the pressure gradient across the liver so that blood flows across the liver instead of backing up into those portal veins. Octreotide decreases our gastric production and also causes vasoconstriction in the GI tract. So that vasoconstriction would be helpful because it's going to help to, first of all, decrease the amount of blood flow that we have, and secondly, it's going to help to stop the bleeding. In this case here, we have an endoscopic view of some esophageal varices, and you can see the black part down there where they had to go down and sclerose a varicose vein. One of the treatments that was used in previous lifetimes here is the esophageal balloon, and this had a number of different names, including the Blakemore tube. This was a tube that was put down into the stomach, and of course, all it looked like was a big, long Foley catheter, so it didn't look like this, as it's illustrated here, when you put it down. So it looked like a big old Foley catheter. You put this down the esophagus, so it goes down the esophagus and into the stomach. And then we blow up the balloon. So the first balloon is the gastric balloon. It's a big balloon that blows up in the stomach, and it kind of holds that tube from moving back out again. Then the second balloon is the esophageal balloon. That balloon is blown up as well, and that's going to push against those esophageal varices, and it's going to make them stop bleeding. So good idea in theory, right? Well, what happens is that after a few days, the bleeding has stopped, so we think, and so we will pull the tube, and we deflate the balloon. So it's kind of like pulling a scab off. You deflate the balloon, and now the pressure against those esophageal varices is gone. They start to fill back up with blood, and the patient rebleeds. So this wasn't probably the best type of intervention to have, but at the time it made a lot of sense, and theoretically it made a lot of sense. I've seen some surgeons use this just as a stopgap measure while they're wheeling somebody over to the OR. So that might be a possibility too, is as a stopgap kind of a measure, but we don't use this as a general treatment anymore. So here is the esophageal varices again, a couple different processes we can do. We can do the ligation, and that's in most cases it's putting a little band around it, so you see the not the one where the catheter is currently, but look down below it, and you see there's a couple of them that look like they're balloons that are pinched off, and there's a little blue rubber band around the base of them. So what they do is they literally go in there and they put like a rubber band around the base of that esophageal varice. The idea being that that's going to squeeze it off, stop the bleeding or stop the potential for bleeding, and at the same time, hopefully it's going to clot and it's going to start to heal over, and then we won't have the bleeding occur in the future. The second process that's illustrated on the right is sclerotherapy, and in this situation now, again, you see the banded piece there, but they're also going in and they're injecting that esophageal varice with a chemical that is going to cause it to sclerose, or in other words, it's going to cause it to die. Another possibility that we could do here is to put a stent in across the portal vein and the hepatic vein. That'll take some of the pressure off of some of those. This is portal decompression. So this is a possibility for some of our patients who have esophageal varices in order to try to control the bleeding that occurs with them. So let's talk a little bit about GI prophylaxis here. If this blue thing that we're looking at is the stomach lining, then the first type of medication we'd use is sucralfate, or in other words, Carafate. And Carafate, what it does is it lines the inside of the stomach. So it's basically lining the inside of the stomach and specifically sticking to those rough areas where there could be some erosion. So it sticks there and it protects that part of the stomach lining from any further erosion. Kind of nice. Another possibility is we can use an H2 receptor antagonist. So, for example, our ranitidine and some of those other kind of medications. Histamine is going to stimulate acid production. So if we block histamine, then we will block acid production. So that's the process that we're using here with our H2 receptor antagonists. H2 refers to histamine 2. There's histamine 1 and histamine 2. Histamine 1 is the one that you have floating around when you have an allergy. So we're blocking that histamine from stimulating that acid production. Then lastly, we have the proton pump inhibitors. Now, what happens in that stomach lining is the stomach lining is going to produce proton, in other words, those little hydrogen ions or acid, and it's going to pump it into the stomach when it's needed. So we don't want to have tons of acids pumped into the stomach when your stomach is empty. We want to have tons of acid pumped into the stomach when you eat and there's something to digest. So there is a stimulus for this proton pump to start kicking out more acid. Well, one thing we can do to try to decrease the amount of acid in the stomach and allow the stomach to heal is to turn off some of those proton pumps. The way that these drugs work is they irreversibly bind up that proton pump. So if you're conceptualizing it as being like these little gears down here that are working, and then what we do with the proton pump inhibitor is we're going to irreversibly bind that pump. In other words, we're going to make it stop so that it doesn't work anymore. So that's a proton pump inhibitor. Now, you may say, well, okay, if we're binding up those proton pumps, then why do we have to give it tomorrow? I mean, if they're permanently bound, then what's the point of having to give this every day? Well, remember again, the stomach lining is going to regenerate on a very rapid basis. So about every 24 hours, we're going to have to give more proton pump inhibitors because the body has made more proton pumps. Now, this diagram here is illustrating the process that occurs in that stomach lining and the movement of our acid in and out of the lumen of the stomach. So some of the ways that we can try to bind it up are going to be illustrated there. So how are we going to deal with this GI bleed? Well, first of all, let's look for that bloody NG aspirate. Okay, if we have an NG in place already, we can be looking for that. We can have about a 10 to 15% false negative because the NG is in the wrong place. So maybe it's in the top part of the stomach and the bleeding's in the bottom part of the stomach. And that blood just continues to go down through the GI tract rather than backing all the way up to our NG. So about a 10 to 15% false negative. In other words, if we get a negative, that doesn't mean that we don't have a GI bleed. Okay, you got the double negative there, so it means that we could still have a GI bleed. Decreased H&H with an increase in BUN. Okay, now this piece here is important. There's lots of situations that can cause to have a decrease in H&H. There's lots of different situations that cause that. But if we also at the same time have an increase in BUN, we should be thinking about a GI bleed. You know, a lot of our GI bleeds are really occult and difficult to find. So we're going to have to get in there and we're going to have to look for something that is going to really point us in the direction of, hey, this could be a GI bleed. And here is our kind of red flag here. The increase in BUN and decrease in H&H. Okay, why does BUN increase? Blood, urea, nitrogen. Nitrogen is going to be a byproduct of the breakdown of our H&H, of our hemoglobin and hematocrit. So as we're breaking it down, remember again, we're bleeding into the GI tract. So we're digesting blood. As we're digesting the blood, the urea nitrogen is reabsorbed and is going to be excreted by the kidneys, but in the meantime, it increases our BUN. Melena, occult blood, nausea, vomiting, hyperactive bowel sounds. Blood is very irritating to the GI tract. So if we have a GI bleed, we can anticipate that there's going to be hyperactive bowel sounds, coagulation abnormalities, and then shock. A risk scoring system was done, and this was put together for the emergency department for being able to score our GI bleeds. The reason why this was done was to try to give some idea as to how bad this GI bleed is. You know, a lot of times we don't really know. Man, the patient's got a little bit of tachycardia, H&H drops a little bit. Are they really sick or are they just kind of okay? So that's where we can use this risk scoring system. So what we're looking for is a drop in the hemoglobin, or a drop in the systolic blood pressure, syncope, melena, tachycardia, or previous cardiac or hepatic disease. So now my patient has previous cardiac disease and has got a little bit of tachycardia, and the H&H obviously has dropped because they have this little GI bleed. Well, that's 3 of these different indicators, and that patient would need to have inpatient treatment, most likely in the intensive care unit. So when we're looking at GI bleeds, these are the things that we're going to be looking at to tell us how bad that bleed is. Other than, I mean, obviously somebody comes in, they're vomiting all over the place, and their blood pressure's in the toilet, and, you know, I mean, that's easy to pick up. But the ones that are kind of stable, that's a little bit harder to figure out how sick that patient could be. So our management is ICU admission. Again, GI bleeds, you know, you can't put your finger on it and make it stop. So until we've scoped this guy, until we've done something to make that bleed stop, we have to think that it's probably continuing because we can't see it. It's internal, and there's bleeding into this big hollow organ, the stomach, the whole GI tract, big hollow organ. Lots of room for blood. Manage the coagulopathies, blood replacement. Packed red cells, try and get our hematocrit back up there. FFP, platelets. Okay, remember, we're not just using up red blood cells. We see lots of red stuff all over the place, and we think, oh, red blood cells, we need red blood cells. But we also need the FFP, and we need the platelets because we have the clotting factors in there too. And we're losing our clotting factors disproportionately to the amount of blood we're losing because they're all being directed to that area to try and stop the bleed. Hemodynamic support, gastric acid reduction by one of those methods that we talked about earlier, the proton pump inhibitor, the H2 blocker, or the Carafate. So these are the three things. Until we do one of these three actual interventions, we have to assume that that patient is still bleeding. So endoscopy, angiography, or surgery, until we've done one of those things, we're going to have to assume that that patient is continuing to bleed. Here's another test-taking tip. Teach it. You will retain as much as 90% of what you learn when you teach it to someone else. Share your information. Share the wealth with your coworkers or students to really get it to stick. When you have to think about how you're going to present that information to somebody else, it really helps it to stick with you, and you really help to learn it. I learned so much when I started teaching because, again, 90% of what you learn when you teach it to someone else. If I just sit down and learn it for my own good, and I'm just going through and studying, etc., I'm not going to learn as much as if I teach it to someone else, because then they're going to be asking questions. And I'm going to have to be able to answer their questions. So I need to be able to do that. Well, thank you for joining me for part 1 of the gastrointestinal section of the CCRN review. Let's move on now to part 2 and keep the momentum going.